Greetings, dear friends in the Neuroradiological Society of Nigeria. It's an immense pleasure to connect with you today. And thank you very much to the organizing committee for this opportunity to reach out on a topic that I would consider challenging, as well as inspiring and thought-provoking. Seizures, neoplasms, inflammations. And I think these three entities do live at the crossroads of each other. And I think there is a common melting point when you think about the processes that drive these entities and the manifestations of these entities per se, once they have established themselves in the central nervous system. So though challenging, I think there is a lot that we can learn from this crossroad and from this vicious cycle of seizures, tumors, inflammations that can often coexist. I shall be bringing to you some cases from our own archives, cases that have provoked self-thinking, self-reflection, and self-learning in my own practice. I have no disclosures. My name is Dr. Mankad, and I'm a consultant pediatric neuroradiologist at London's Great Ormond Street Hospital for Children. Very happy to have any of you visit us. If you do chance upon a visit to London, do come and spend some time with us, and we're very happy to share our cases and our learning with yourselves. So going back to the concept of how we understand complex cases like these, here is your warm-up scenario. A 2-year-old boy who presented in a rather stable neurological condition, but had fever and a bit of deterioration and a scan that showed signal changes in what one would call as rhombencephalitis involving the hindbrain, the tegmentum, the cerebellar peduncles, and the CSF examination in this child was positive for enterovirus. So the question instantly was, are we dealing with a primary viral problem, or is there something else? Well, at the outset, there was nothing else to treat, so this was treated as a viral entity. But the first thing to remember also is that viruses often inflict a lot of para-infectious phenomena in the brain. And so there is a whole school of thought whether early immune modulation with steroids is recommended in such patients, apart from giving them antiviral therapies. This child was commenced on steroids because the antivirals were given. There was no clear change apart from the fact that they remained relatively stable neurologically. And then a repeat scan a few weeks down the line shows these appearances where there is some resolution of the angry-looking tegmental changes or even the peduncular changes. But there was this lesion which was in the cerebellar vermis, which seemed to have grown from where it was and was also enhancing almost in the pattern of a Christmas tree in the cerebellar vermis. The discussions that ensued were whether this represented in itself disease progression in terms of a primary infective etiology or something else. The decision at that point was to wait and watch and repeat scan in 3 weeks, where we see that that particular lesion in the vermis has grown and continues to rapidly enhance. And you can see early atrophy as well in the cerebellum, and that was accrued to the use of steroids. Questions from this real-world case were, is this primary infection? Is it a para-infectious phenomenon, or is it something else? But given the growth, given the mass effect this was inflicting on the surrounding structures, this particular lesion was resected, and it turned out to be a pilocytic astrocytoma. This case still remains very open in my head, and I did go back to the pathologists to ask them if there was a lot of inflammation in the tumor environment when they saw the specimen. That was a hard question for them to answer because astrocytosis would be a feature in itself of an astrocytoma where there is glial proliferation. And the second question, which remains unanswered, is whether having inflammation in the environment of a growing tumor potentiated its growth, because one would not expect a pilocytic astrocytoma to grow so rapidly in the short interval that we were looking at. Looking at the big picture, however, And the fact that what we call as tumor or tumor factive is just really a manifestation of inflammation in itself. The four cardinal principles of inflammation, whether it is a skin cut with an antigen entering the body or a deep within CNS inflammation that has been encouraged by a virus or other organism, for instance, essentially follows the same steps. There is tumor, which is swelling. There is dolor, where there is pain, calor, or generation of heat, and rubor, or redness. And these four aspects of inflammation have not principally changed in all these years of understanding what is going on. So focusing our attention on the environment of tumors, there is the immunosurveillance side of the body, which continues to monitor and prevent tumor growth. And that in itself has a cascade of pro-inflammatory performers or mediators, which kind of keep a check on the body forming tumor cells. And if they are formed, they continue to destroy anything that is foreign to the body. When that process goes out of balance, then there is an imbalance and tumor can proliferate in spite of having an immunosurveillance. Definitely, if there is a problem with immunosurveillance, like an immunodeficiency syndrome, for instance, that balance is definitely lost. Inflammation in itself can be produced by the fact that there is a tumorigenic environment in the body, and tumors can promote inflammation. So tumor promoting inflammation, immunosurveillance, and tumors, they are in some kind of a strange balance with each other. And when that balance is disrupted, we have the presence of extreme inflammation with tumor, and then it's harder to understand what is the primary driver. Also suffice to understand here that there is a lot of focus now on keeping the inflammation in the body low, particularly with anti-inflammatory diets or medications, not just to prevent cardiogenic problems like atherosclerotic heart disease and other things, but also tumors. So inflammation in itself can promote tumors. And that is something we need to keep an eye on when we encounter strange cases. But just magnify into the glioma environment here in this picture to show you how the various players of inflammation, the macrophages, the cytokines and the other chemokines, the other growth factors, the tumor factors, the neutropins, and the idea of excitotoxicity with reactive astrocytes have an interplay with the tumor environment. And that is kind of zooming into what we just saw earlier on. So when we encounter cases like these, and this is my set of 3 different cases, you can see the axial T2s here, the instant question that a radiologist is asked is, what is this and should we biopsy it? Something to consider quite strongly is the fact that when you have a lesion in the brain, and if you think that the yield of biopsy is going to be poor, which used to be the historical thinking, that there was less than 40% hit rate for getting something accurate, that number has been revisited now. So first of all, let's look into case 1, 2, and 3 a little more in depth. Case 1, which starts with a CT scan, with the cerebellar changes on the right, quite a lot of diffusion change where the radiologist gave a differential of either acute inflammation or, in addition to that, the differential of a high-grade infiltrative glioma. And on pathology, on histology, this turns out to be a cerebellitis. An infective organism was not found, but most likely a viral etiology was considered. Second case was of this particular patient, a 15-year-old boy, who had infiltrative disease within the cerebellum. And it's very hard to tell if this is primary inflammation or tumor in itself. These lesions, the high-grade gliomas, as in this case, can involve other areas, for instance, the brainstem and the high cervical cord in this case, without any diffusion restriction, though there are areas of low and high reduced diffusivity. And in addition, the contrast side did not help as well. And it's important to remember that high-grade gliomas may not enhance on contrast administration, and it may not always, frankly, restrict uniformly as well. So a low threshold to biopsy would give an early diagnosis in cases like these. The third of our first set of cases was this 2.5-year-old boy with acute headaches and vomiting. And you can see that there is quite a tumefactive process. It's quite a diffuse process involving the brain. Everything is enhancing. And in fact, the spectroscopy also shows a choline peak. And this was a case presented from center in India, where the initial differentials were not clear and diffuse glioma was entertained once again. I would like to focus your attention on this perivenular or perivascular nature of this particular disease. This turned out to be a rather novel or emerging condition in the inflammatory spectrum of immune-mediated disorders, a GFAP astrocytopathy. And in GFAP world, there are some examples in the case reports that have been published, and you can see that there are some common themes, them being perivascular distribution, or even causing a definite leptomeningeal enhancement in the brain, or just non-specific lesions like in our case. Overall, the outcome was not bad of our particular child here, a little bit of frontal injury, which was scarred, but he did quite well, and you can see that he looks very well in himself. And the video kind of goes on to show that he was doing not badly in terms of cognitive as well as motor outcomes. So about biopsies, therefore, if in doubt, do it early. Doing it early alters a natural course of things, and doing it also makes a difference in up to 70% of cases, as shown in this paper from our own center, looking at the data from 2016 to 2020, when this was published. The second question a radiologist needs to answer is when not to biopsy. And sometimes we really have to hold the surgeons back. 3 different cases here. You've got extensive spinal cord changes in the first one, brainstem changes in the dorsal aspect in the second one, and here a child presenting with worsening seizures, who is what was called as potential glioneuronal tumor with hemorrhage and calcification in the right temporal lobe. So case number 1, breaking down into 3 different parts. The brain was normal. In this case, child was quite encephalopathic, 8-year-old. And when you see extensive myelitis, here you could call it soap bubble in appearance with enhancement, then you have to think about immune-mediated disorders first. This turns out to be an aquaporin 4 NMOSD. The second patient was this patient with lesions which are quite symmetrically involving the dorsal aspect of the brainstem, also enhancing. And one wondered if there were some kind of periventricular signal changes, but that is a very soft sign. This child was referred for proton beam therapy or PBT for us after 18 months of workup for everything, including aquaporin 4, etc., because it's involving the area postrema, except that there was one test that needed to be done, and this turned out to be an Alexander's disease. All it needed was one simple either blood or skin test to confirm the genetics of Alexander's in this case. Not a tumor, definitely not a candidate for proton beam therapy. The third of this set is this lesion here, which also shows some pre-contrast shortening, but also post-contrast enhancement, and worsening temporal lobe epilepsy. But this is something that you wouldn't really want to biopsy, and I'm sure the smart neuroradiologists in Nigeria would have called this an aneurysm of the right MCA, like we did, but it took a long time for this diagnosis to be made because not all centers are aware that aneurysms can form in children, and when they do form in children, they can be quite complicated, complex, lobulated entities with dysplastic blood vessels underlying them. So when to biopsy, when not to biopsy. The third thing to look out for is if you were to not be sure of what to do, then generally the discussions that follow is, can we do a spectroscopy? Can we do a perfusion? And I can tell you that in the acute inflammation state, these are not really useful entities. Here we have a lesion. You can see in the thumbnail pictures there that there is patchy changes on the left side, and a choline peak on spectroscopy, the perfusion not really helping us either way. And this is essentially is an entity called MOGAD, which is myelin oligodendrocyte glycoprotein associated disease, one of the mimics of multiple sclerosis in the spectrum of relapsing demyelinating syndromes. And I'll let you look at that picture. You can see the enhancement as well, which is spiculated or nodular within that substance, looking very much like our GFAP astrocytopathy case, if you think about it. But these are the immune-mediated inflammatory disorders. And spectroscopy, not always useful. Spectroscopy not always useful. Perfusion can be high or low, and it's irrespective of the tumor grade as well. If this was a tumor, and you can have increased or reduced perfusion even in the context of inflammation. So be a little careful about trying to use these advanced imaging techniques to try and answer a question. You might not always be successful. Whilst we are thinking about inflammation, epilepsy, tumors, and seizure states, we should not forget that there is a big overlay between malformations and tumors as well. And malformations in itself can present with seizures. Here we're looking at two different cases involving the cerebellum. And this was a child who presented with seizures and developmental disorders. Now, it is a very unexplored area whether cerebellum can drive seizures as well. But both these children had seizures, and the second one, an older girl, also had ataxia. And this particular scan was read as negative. You can see it's a very subtle change that I'm trying to show here in the left dentate nucleus. So case number 1, this was their outcome. This was called the dysplasia of the cerebellum and nothing done. And they came back with a large tumor a few months later. This was a medulloblastoma. And medulloblastomas do develop in dysplastic appearing tissues, which can have low T2 and low ADC values. So early in life, when you encounter that, keep a closer watch. The second case here, this is the diffusion changes on the sonic hedgehog medulloblastoma and the T2 low changes that you had seen previously. The second case was this girl with ataxia and presenting with wobbly and seizure-like episodes, and in a few months' time, in fact here a longer period, 3 years later, presented with what was a more diffuse medulloblastoma involving that cerebellar hemisphere. So don't believe me when I say that tumors can essentially take a long time to manifest themselves, and they may have been present in some format or the other much before we think they were. And particularly in the posterior fossa medulloblastomas, they start somewhere and they're not always acute or subacute phenomena. So to believe me better on this, you will have to look back on any previous scans of your patients, if they were scanned for whatever reason, and see if there is any inkling of something that looks like a tumor to start with. This is a bit of an excerpt on why these particular medulloblastomas develop in the particular states they are in, and the interplay between genetics, particularly the sonic hedgehog pathway, which leads to not just medulloblastoma formation, we have malformations as well. So there is a very close genetic link between malformations and posterior fossa tumors. Tumors are, however, evolving landscapes. I'll give you two different examples here. And we are going back to the epileptogenic tumors, particularly those which have been referred to historically as DNETs or gangliogliomas. And we know radiologically we can distinguish between the two. Some years ago, our pathologists published this paper where they wanted to move away from labeling things as gangliogliomas and DNET and look at their genetics in terms of what was the enrichment happening in terms of genetics in these tumors. And they had a BRAF enriched environment and an FGFR1 enriched environment, based on which they decided to kind of classify these glioneuronal tumors into group 1 and group 2. When I saw the paper, I said, let me look at their clusters in terms of what the imaging features showed. So this was the cluster 1. Now, cluster 1 is the BRAF enriched environment. That means they're mostly astrocytic expressions. And we saw that all of the tumors were temporal and mostly medial temporal. Half of them would enhance, and if they did enhance, they had this very hazy, out of focus kind of enhancement, as if somebody has taken a picture and the camera has moved a bit. And they had ill-defined margins. This was our type 1, so you can see the radiology was quite strong. And then this was a type 2, where we had tumors which were not mesial temporal. So even if they were in the temporal lobe, they would be in a non-mesial temporal location, but they were generally extratemporal with the flare rim. And this is one of those tumors where we would call them DNET and leave them, but most of them may not always be DNETs, but most of them would show the other features, the flare rim, the well-settled crab nature, the fact that they tend to go towards the ependymal margin. And therefore, this was a very easy radiological win, because we knew that these two entities were going to be different from each other, but they did follow their genetic expression quite strongly. Here's a companion case. This is not a low-grade epilepsy tumor. The child did present with seizures, and you can see that this tumor here is not causing anything in the way of tissue reaction around, no edema, heterogeneous, on flare, very difficult to distinguish it from normal brain tissue, did not really enhance at presentation. And these were quite low on ADC values. So this child was called a supratentorial PNET in 2020, 2014. But essentially, when things get revised in terms of terminologies with the WHO classification, these samples were looked at again, and it was relabeled as an ETMR, as in a pretty aggressive embryonal tumor. This child also has some prematurity, so this is not related to the tumor, but they did have prematurity-related changes in the brain. So very short history, not exactly a long present epilepsy causing tumor. And then this child had resection and radiotherapy and other therapies given to them over time. And the radiologists were reading these changes in the frontal lobes on the follow-up imaging as no tumor recurrence, ongoing therapy-related changes. Only after 2 years, I saw the scan and I was a bit worried and concerned about the fact that these so-called radiotherapy changes were increasing each time and were quite much causing a mass effect with expansion of the corpus callosum and also splaying of these cortical sulcal folds, little bit enhancement in parts which were not enhancing previously. So we asked for a review at the multidisciplinary team meeting, and this eventually was declared as a radiation-induced glioma. And we will encounter a lot more of these where the recurrences are not real recurrences. They don't look like the original tumor, and they fall in the remit of radiation-induced gliomas. A lot of children are surviving with cancer that has been treated previously, so be aware. And this is not an inflammatory change in the brain. This is not an infection, though the child was worked up for everything before subjecting them to a rather generous biopsy. Final message in this realm of inflammation, neoplasm, tumefactive lesions, and seizures and states is this. A 7-year-old girl with explosive onset seizures, and a natural history is very important. We should read the right books, not just radiological texts. The moment I tell a neurologist explosive onset seizures, they start thinking Rasmussen's encephalitis. But all we had on the imaging was a patch of signal change, which was subcortical white matter primarily in the insular region on the right, not restricting, not enhancing. So this was called seizure-related change. So next time you call something seizure-related change, make sure you want to follow up that patient because the seizures kept getting worse in this child, and you can see that the signal change also kept getting worse. It was every signal change would have some mass effect, and it was a bit swollen out there. So the child undergoes a biopsy because a diagnosis of gliomatosis cerebri was made in those days when this was still a diagnosis that could be made, or a diffuse glioma as you would call it now. The biopsy came back as not conclusive. And whilst we were still scratching our heads, the child continued to have very bad seizures, and they had explosive seizures still getting worse from the right side. At 2 months, at 4 months, things get worse. And at this time, a decision was to re-biopsy because we said maybe there was a sampling error on the earlier biopsy. And on the re-biopsy, what you have is, yet again, all chronic inflammatory changes, this time no evidence of neoplasm. And the pathologists were quite adamant that they had enough sampling and they were not seeing any tumor out there. So you can see the child is still suffering in the background and eventually needed a disconnection surgery because the revisitation at this particular time, only 12 months later, we were able to see a hemispheric atrophy and a diagnosis of Rasmussen's encephalitis was therefore made. The treatment of which would have been a disconnection surgery, child had disconnection and very good seizure control after that, apart from the comorbidities associated with the functional hemispherotomy. So what started as seizure-related changes, then was called tumor, then was called worsening tumor, and finally shows atrophy in the affected hemisphere. Biopsy was not extremely useful, but useful enough to tell you there was no tumor there. And chronic inflammatory changes in themselves need to be questioned as to what they mean. So final diagnosis here was Rasmussen's. Now it's interesting, we think of Rasmussen's as an autoinflammation or an autoimmune process. But I went back to read into the radiology and pathology books as to how Rasmussen's was described. And the description of Rasmussen's is that there may be dystrophic neurons. So it actually may be a malformative process of the brain rather than just an autoimmune inflammatory process. So we are still understanding many of these disease states. We haven't really got to the bottom of things. And it's important to correlate what we see on imaging with what has been said in pathology and what the surgeons see when they go in, and then to question our pathologists a little bit more in terms of how far they can take the so-called gold standard further. I would like to conclude with these acknowledgements and this little picture here again, all the various players of inflammation and tumor, and all of these entities would definitely cause chronic seizure states, which would have been labeled as epilepsy in itself, until we find the etiology for the epilepsy or the etiology for the inflammation or even the associations of the tumor. So keep that inflammation down. Thank you very much for this opportunity. And I just wanted to put this piece together to provoke some thinking next time you saw a non-specific patch of signal abnormality in the brain. Thank you very much for your attention.